Hello, everyone. We're ready for another club webinar. We're at number 97. Excellent topic tonight, one that I enjoy very much. We're going to talk about coding for CHF or congestive heart failure. And one of the things that we did was combine several aspects. We're going to talk about the disease process. We're going to talk about CHF and what it entails, but then we're also going to tie that all into how it relates to the code set, ICD-10. And if you have questions along the way, since we're doing a club webinar, feel free to ask. I'll keep my eye over there. But it is fascinating how the disease process and the code set have this relationship. And I want you to let me know if you see that as well. We're going to be able to continue our conversation after this webinar in the CCO Club. It's really easy to find. It's www.cco.us/club. Not only do you have access to our webinars and the support calls, all the different webinars that you see in our relays, but we also answer questions related to this field in the club, and there's a lot of extended product support. But ultimately, it's just a fabulous community to get together and discuss. Even as a student, if you're just interested in this as a career path, or if you are out there in what we call the real world and you're actively coding and you come across a scenario that you need another set of coding eyes on, we're there to help you out with that. Let's talk about CHF itself. From this point on, I'm just going to refer to it as CHF instead of congestive heart failure, because most of the time you see it documented, it's always CHF. Nobody ever writes congestive heart failure out. Ultimately, what is CHF? Don't be confused, because if it says heart failure, that's not the same as a heart attack or that the heart has stopped. It is not the same. It is just meaning that the heart is failing. And what is the heart failing to do? It's actually not able to pump the blood like it's supposed to. And it ends up being a chronic condition. This condition can last long. It becomes chronic, so it can start out as people not having many signs and symptoms or having much trouble with it, but it ultimately is something that's never going to get better, right? And so it has different stages that we're going to talk about, just so that you can understand the types and how the code set defines them. Ultimately, when the heart is not able to pump the fluid through the body like it's supposed to and is designed to, then other organs start becoming damaged, as well as one of the other major signs and symptoms that you'll see is fluid starts to build up in the body. You start getting lower extremity edema, you get ascites in the abdomen, and the lungs get fill up with fluid. Uh, Heart failure itself is divided up into the left side or the right side failing. Actually, the left side has two specific types. We'll talk about that. But I thought this was really, really interesting. And I actually referenced several of the things that we're going to talk about on the slides tonight from Cleveland Clinic. I like to go out and use Mayo a lot, because I think Mayo Clinic is very educational and the way that they format and give their information to the public. And being such a huge research center, Mayo Clinic is really exciting to be on their website. But I was able to find some fascinating stuff from Cleveland Clinic. And again, most of this is referenced from there, which I notated that. But one of the facts that came out of this is they said that 6 million Americans have heart failure, and more than 870,000, 800, yeah, 870,000 people get this diagnosis with each year. That's crazy. That's that is almost a million people every year are getting a CHF diagnosis. Now, when you think about how many people live in the United States, pretty fascinating, right? Heart failure or congestive CHF is the leading cause of hospitalizations of people over 65. Now, that is important for a couple reasons, and that makes my eyebrow and little coding senses go off because one, I'm very heavily involved with risk adjustment, and risk adjustment for the most part is based off Medicare patients, which is 65 years and older, even though it does other ages too, because that's CMS HCCs and they have HHS HCCs. But with that being said, that tells you how prevalent this diagnosis is. And therefore, it's going to be something you're going to come across as a student and in your career again and again and again. So it behooves you to become as knowledgeable as you possibly can regarding this disease. It's going to help you as you test, but it will for credentials, but it's also going to help you just be a better coder, more accurate and faster, to be quite honest. So we've got several things that we're going to talk about regarding CHF. Let's divide up the different types that I had said. You can have the left heart and you can have the right side of the heart. The left side of the heart has two different types of heart failure. One is with reduced left ventricular function, and the other is also left sided. It's with preserved left ventricular function. Now, there's several terms that we're going to use repetitively, but if this is an uh, something that's new to you, if you're just learning the disease process, it's very important in this career that you are familiar and really knowledgeable about the heart itself. I am upfront when I say what you need to have memorized and what you just need to be aware of, right? So I'm always telling people you need to know the bones of the body because that's how thing you learn. Other areas of the body are named after bones of the body, and then the anatomy of the heart. You just really have to get that memorized, and it's not that hard. Meaning, you got a left side or right side, you got atrium, ventricles, and the major and your valves, and then the vessels going in and out. That's kind of it. But again, the left side ventricular, which is the lower chambers of the heart, and there's a right side. So you have one of each, but there's two things on the left, and CHF excuse me, likes to affect the left side first. Excuse me. Ultimately, what happens with this reduced left ventricular function is that you are going to have the heart getting bigger, and it can't do its job. It can't squeeze, doesn't have that power with the reduced left. When you have preserved, really your heart's working normal, but the muscle of the heart, the ventricles are thicker and stiffer, and they can't relax properly to fill back up. So again, it's that pumping action. If it gets sluggish in any way for whatever reason, fluid backs up. Now, right-sided heart failure is usually uh, falls after the left sided, which is the most common. And then it starts getting into the other organs like the lungs once you get to that point. Now, it's important that you know that there's left sided and right sided because that's going to make a difference in the code sets. And as we talk about systolic, diastolic, so on and so forth. So we'll talk about that. There are many complications of CHF. Now, why do you need to be aware of these? Because there's codes that have uh, code for comorbidities. And you have to understand the difference between signs and symptoms and complications. Because in the prophy and outpatient world, you don't code signs and symptoms when you have definitive diagnosis. Inpatient, you can code all of that, but for the most part, people work in the outpatient realm, and these complications can sometimes be signs and symptoms, and sometimes they're not, but they're linked to the disease process. Quickly, irregular heartbeat, so any type of an arrhythmia that may be associated, and with these arrhythmias, it could be, AFib, A flutter, and all the different types. And so that's one avenue that would add another code. Sudden cardiac arrest, so the patient could have a heart attack. Heart valve problems, the valves themselves wear out. A collection of fluid in the lungs. This isn't necessarily the same thing as pneumonia, but it is pneumonia in the fact that the lungs are filling up, but there's not necessarily infection and stuff. There's fluid on the lungs. Pulmonary hypertension was just a very specific type of hypertension. Then there's kidney damage. We're going to talk about that relationship between the kidneys and the heart. Liver damage and malnutrition, all very common to see as complications of CHF. Now, signs and symptoms, a little bit different. You're going to see things like SOB. You're going to see the patient being lethargic and fatigued and weak, uh, especially with their legs. With CHF, the legs are affected, and one of the first things that they see, besides shortness of breath, is that the legs start filling up with fluid, and they have trouble with their legs. Swelling, that edema that happens, swelling of the ankles, legs, and even the abdomen starts to swell and can fill up with ascites. Weight gain, you start having sudden weight gain because of fluid, and it's very you can fill up with fluid quickly and have a sudden onset of weight gain of 5, even 10 pounds. You have to go to the bathroom at night, and uh, uh, it again, this isn't the same as a prostate problem, but that you have to get up and urinate more often. Rapid or irregular heartbeats where you have palpitations. And then we have a dry hacking cough. Now, that is unique. And I think it's funny that I was coughing. Mm, and that's only because I've been talking all day long. It has nothing to do with that. A dry hacking cough, and also feeling bloated, not being able to eat because your stomach is uncomfortable. You have a problem with your appetite or an upset stomach. You can have nausea, a lot of nausea. All of these tend to be signs and symptoms of CHF. They can be signs and symptoms of other things, uh, but you start adding a few of these together, those are definitely red flags, especially when you add in the patient's age, and then we look at other diseases and comorbidities that can happen. When we look at stages of CHF, now the stages you do not have to have memorized. I put them in here only to help you understand the disease process, and probably it will highlight the documentation that's involved with these. So I wanted again to make you aware, but you're not going to see the stages. In fact, unless you're working with a cardiologist, you're probably not even going to see that uh, the stage is even documented, right? So primary doctors are not going to do that. So we have hypertension as being part of stage A. This is really that beginning process, and hypertension is a giveaway for a lot of disease processes. Diabetes will can be involved, and uh, that you can have more than one of these areas. CAD, metabolic syndrome disorders. You could see a history of alcohol abuse because the liver is going to become problematic if the liver isn't able to function well. History of rheumatic fever, also cardiomyopathy in a family history. And then if there was any drugs used that could damage the heart, that could be part of it. Also, cancer, some cancer treatments, both radiological and chemotherapy, can affect the heart and make it predisposed to CHF. Stage B, when we follow along, that's still considered, pre heart failure. But the takeaway from here is that you're going to go in, they're going to go in and see their primary care doctor, and they may see that systolic left ventricular dysfunction. I'll describe that a little bit more in the future here, but they've never had any symptoms of heart failure in the past, and yet they're able to identify that. A lot of times they stated that stage B will show up on an echo. So they might have a few signs and symptoms. They go and do an echo, and then boom, they do the ejection fraction and are surprised. Whoop, we got a diagnosis of CHF, or we're getting to that point. The stage C is when the heart has started to fail. And this is going to have your signs and symptoms that we saw, but the patient's going to have more signs and symptoms, not just one or two. And they came and they had an echo done, or because you had a family history and so on. The patient is walking around with shortness of breath. They have the tiredness. They're not able to exercise. They get really tired and weak just walking across the room. Staircase is not a good thing for them. Leg weakness, they stumble a little bit. They are going to the bathroom a lot, and they're having a lot of swelling in the lower extremities. Now, when you get to stage D, that's the advanced stage. That's where you're at end stage heart failure. And excuse me, there's not really much that they can do for that. There's really, honestly, not much they can do for these stages, period, except for that when you're in like A and B, you can make lifestyle changes that will help. But once you started that slope of going into CHF, it usually prevails, and it's a matter of how you take care of yourself and how they treat the signs and symptoms to keep the heart healthy as long as you possibly can. Well, then you might ask, well, what are the causes of CHF? And there are several things that can cause CHF. It may not be solely lifestyle. Maybe you're thinking morbid obesity, and then you don't take care of yourself and you don't eat right and so on. But let's look at what could cause them, and some of them we've already mentioned. But CAD, you already have coronary artery disease, so your arteries are not in good shape. Definitely, if you've ever had a heart attack, you have death of heart tissue. The heart cannot regenerate itself like other cells. Those cells in the heart muscle, once it's damaged, it's damaged. The rest of the heart has to compensate for it. That's the same way as the brain. Once there's damage, it's done. However, like the heart and the brain are similar in that, and that other parts of the organ itself can compensate and help, but it's never going to be at 100% again. Now, and that leads me to another point, that as you advance in age, that organ has less and less ability to compensate. So if a person has, say, for whatever reason, damage to the heart muscle at a young age, then the the heart compensates. It works around it, kind of, as you would say. Same thing happens to the brain. But when you get into a more advanced age, those organs aren't able to do that anymore. Cardiomyopathy, congenital heart diseases that happen at birth, again, will predispose you to having CHF. But when you take care of the heart, you can put that off as long as possible. Diabetes just messes with every organ system. It is harsh. So when you have diabetes, you can have damage on everything, and the heart is one of them that a lot of people don't talk about, right? Yeah, high blood pressure, hypertension. A person that has hypertension and it's chronic and it's not under good control, that destroys a heart very quickly, and the other vessels, which in turn messes with other organ systems. And I when I say that it happens quickly, I guess I should rephrase that and say it's kind of like a slow burn instead. So it's like, the story of putting a frog in a hot skillet, it'll jump around, but you put it in a pot of water and slowly heat it up. That's kind of the way hypertension works. If you don't stay on top of it, you don't really always get a lot of signs and symptoms with hypertension, depending on, if it's the upper, systolic or diastolic, then you're not aware until the damage is done to your other organs. Arrhythmias, any type of arrhythmia will make you predisposed to the heart having to work harder to do its job. And as a result, the heart starts to fail. Kidney disease. I, you know, Ultimately, when we wrap up here with this lecture, I'm going to talk about the the heart, the lungs, and the kidneys having this relationship together, that if one has an issue, then the other two are affected, and it doesn't matter which one. Though it's kind of like a triad in itself. Obesity. We know more about obesity now than we've ever known before, and the cause and damage that it does to the body. Tobacco and recreational drug use, and then other types of medications that are used, especially things like chemotherapy and even radiation. So let's talk about some coding tips now. Uh, we've established the disease process. We understand what CHF is and some of the verbiage that you're going to see in the documentation that you will look at, especially if you're doing risk adjustment. I couldn't help but throw in this risk adjustment information because I enjoy it so much. So I can't help but throw that in there. But let's look at things you'll see in documentation. Family history is very, very important. If a patient has any type of uh, heart disease, then they're going to be, you will be predisposed to having CHF and other things. Personal history of the cancer treatment. And we mentioned that because chemotherapy can be very hard on the heart, as well as radiation treatment. I know that it, when my mother was going through her chemo treatments, she had to also see a cardiologist every 3 months because one of the drugs that she was taking for her chemo was very hard on the heart, and hers did fine. Tobacco and alcohol use. So, when you are looking at a patient's record and you're abstracting that information, look for things like tobacco and alcohol use, abuse, and dependence. Any of those could become problematic and be heads up that CHF is also involved. Comorbidities. Uh, the three major ones that most people talk about is going to be the hypertension, the CAD, and cholesterol, having high cholesterol. If your patient has diabetes and CKD, one or the other, or both, there are specific coding guidelines surrounding that and CHF. We'll talk about those. But if this is something that's new to you, be very aware. Diabetes and CHF, that's a big deal. S- uh, when a patient has CKD, and especially when you get into, stage 4 and above, CHF right there at the same time often. So the code we look at for CHF is going to be I50. Now, if you are a student or if you're testing, that is something I would write in my notebook, and I would remember CHF I50. Now, you're going to use more characters than that, but for people who are testing, when you go to abstract and rule out when you see your multiple choice, if you memorize that I50 is a CHF code, then you can look real quick. Does the patient have CHF? Do I see CHF? Okay, it says CHF and it tells me it's systolic. Right there, I have a higher diagnosis than just I50.9, which is just unspecified CHF, very common code that's used. So again, they like to do that with testing to make sure that you understand there's several different types of CHF. When you don't have to have memorized is the fourth and fifth characters. Let's look at the fourth character. If we have systolic CHF, it's a 2, diastolic is a 3, and if you have combined, which is systolic on diastolic, it's a 4. Now, if you were to memorize that or have that as a note in your manuals for you, then you could easily abstract and rule out very quickly. If you saw that the note said I50.2 and you looked up and it said diastolic, CHF diastolic, and it wasn't combined or anything, then you know the 2 isn't right. It's going to be 3. So again, those aren't necessarily things that you memorize for testing, but if you have a little note in your manual at where I50 starts, then that'll be beneficial to you. The fifth character just kind of sums it up. 2 for chronic, 3 for acute on chronic, and CHF is chronic. Now, for risk adjustment, for meat, and just for coders in general, though, is that there's a lot of tests to determine that the patient has CHF and or the level of CHF that the person has or the type of CHF. And this list of tests will give you that. So when you look at the plan of care, you're going to see that they did a chest x-ray, they identified something, so now we're going to send them out for an echo, or they did an MRI, or we're going to have the patient do a stress test. These are very common tests to see that cardiac catheterizations to determine either that the patient has CHF or where they are in the type of the severity and the type of CHF that they have. So the stages of CKD, you need to have those not memorized, although it's not that hard to memorize them. But CHF and CKD have this causal relationship together, right? If a patient has CHF for very long, they probably got CKD, at least CKD2 and maybe 3. And then if a patient has CKD over a long period of time, and especially when they get hypertension involved, then what does that cause? CHF. So just a quick review that the stages of CKD, N18 is your code, and the stage is super simple, point 1, point 2, point 3, point 4, point 5. Although be aware that stage 3 is now has an additional character because they have stage unspecified, stage A and stage B. Then, if a patient has stage 5 or 6, they're probably well, if they have stage 6, they're absolutely on dialysis. But if they're on stage 5 and they're starting dialysis, Z99.2 is that dialysis code. Just kind of giving you a tip there and letting you know that these are codes that are very common with CHF codes, and there is a relationship there between them as well as hypertension. Then with hypertension, and this is where talk about that triad. In fact, I had thought to put a triangle in there, and that's why I left a little space, but I forgot to do it. So kind of picture a triangle on that triad. So you have the heart failure, they have the CKD, and the hypertension. With hypertension, I10 is hypertension. And there's several types of high. You can have benign, you can have malignant, all this other stuff. That's I10. However, once you get into the hypertensive heart disease, that's one step further. into the disease process. That's not normal hypertension. And that's the way I try to memorize that, is that that's a one, where it's not I10, it's I11. We're one step closer to having more complications. So I11.9 is hypertension or hypertensive heart disease without heart failure. So we don't have CHF yet. Then if you are I12.0, then that's the hypertension with CKD. Okay, two organ systems, the heart and or the you've got hypertension and you've got the kidneys, so that's why it's a two. And there's two choices. You got 0 and 9 for or different stages, but then you move into I13. Now, 3 signifies you've got that triad going on. There's a triangle. You have CHF, you've got the heart failure, you got the CKD, and you got the hypertension. So there's 3 things happening, and there's 3 options for you. You can have hypertensive heart failure with CKD, and you can have it without heart failure, and then it involves the stages. If you have a patient that has CKD, you always add that CKD code with these other codes, right? And that's the coding tips that you need to know. If you have I13.2, then you're going to put the CHF code in addition, right? You got to identify that, yes, the person has what? If they don't know, it's I50.9, then they would be, N18.5 and I13.2. Those 3 codes would go together as an example. All right. Moving on to the coding tips, we got to think about the documentation. What are we going to see? Now, these are things that, again, you don't have to have memorized, but the reason I wanted to add this slide and give you this graphic when I found it, I thought, wow, this is excellent, because this is what you're going to see in the documentation, especially from cardiology. And you are going to see these terms, and I wanted you to be aware of them, both so that you would see what some of the signs and symptoms were, like anxiety and confusion. Your O2 stats are starting to drop. You're weak. Your skin is cool and moist to the touch. The dilated pupils because we're not getting enough oxygen, right? And the pale skin, they're gray, they're cyanotic, things like that, right? Now, on top of that, though, we are going to see ascites, right? That's where that fluid starts building up in the abdomen. You kind of see that they're showing you that yellowing. Enlarged spleen and liver because they're having to work so hard. You'll hear the provider mention or document S3 gallop or tachycardia, right? The jugular veins are distended. So this is all stuff that they're going to notice in the exam portion. And these are leading that provider to CHF, or they probably already have CHF and it's documented, but it's going to be helpful to you and make you a more accurate and faster coder when you know the common signs and symptoms of any disease process. Sorry, I didn't mean to hit that. All right. Now let's look at the codes themselves. And I see some questions and notes coming up. Lisa says, hi, Alicia, there's an excludes note with N18.5 saying CKD5 requiring chronic dialysis N18.6. So we don't use Z99.2 with stage 5, right? Well, the Z99.2 is stating the patient's on dialysis. If that excludes 2 that you're seeing is stating that an N18.5, which is a stage 5 CKD, once they start dialysis, it then moves or advances to N18.6, which is end stage renal disease. That's what that excludes is about. It's not about the dialysis. And it's you may think it's like diabetes. All type 1 diabetics take insulin. You don't necessarily need to code Z79.4, long-term use of insulin, right? It's kind of redundant. Well, all ESRD patients require dialysis for the most part. There may be some scenarios, I guess, when they don't, where it's a temporary thing or something. But no, you would use the patients on dialysis for stage 5, and you could use it for stage 6. Uh, I I code it. I use it every time the patient's on dialysis. One is because it's a statistic. Unless you have a protocol where you're working where they say no, you don't have to code the dialysis is Z code because they're end stage renal disease. But again, I don't know very many places that do that. So that excludes is about, hey, heads up, in 18.5, once they start dialysis, it moves up to end stage renal disease, which is in 18.6. So I hope I answered that for you, Lisa. That could definitely be a coding question, by the way, is that end stage renal disease, once that starts, if the patient was a N18.5, or if they say the patient is a CKD patient stage 5 and they're starting dialysis, then guess what? They're now an N18.6. It's in the guidelines. You can go look those up. I can't tell you exactly where they're at, but it's on there, or it will tell you there by that excludes note. So, excellent question. So the codes that we look at, remember I told you I50 in that previous slide, that's CHF, I50. The most common code you see dropped, especially now that providers have to use the code it all the time, is I50.9. And there's a place for unspecified. Unspecified, as far as the code set is concerned, means we either don't know what stage it is or where we're at, what type. So we're sending them off to the get an echo, or we're sending them to the cardiologist. We're going to do some more of those tests that you saw. We need to get the EF, the ejection fraction, to determine. So again, it's unspecified, or it's just not documented, and we don't know. So honestly, when you see a patient that's an I50.9, once they've had testing done and that comes in, and we definitely have seen a cardiologist and stuff, we don't want to be using I50.9. We want to know. And if you look in a patient's chart, you're probably going to get a more definitive diagnosis somewhere. So be aware of that. And they will test you on that. They'll give you multiple choice questions, and they'll put I50.9 for 2 of them, and then they'll do I50.2 on 2 of them. Now, there's more. I50.9 is a standalone, but 2, you'll see there's ranges here. That's why I put those ranges, so you'd be aware of that. That being said, or they may use I50.4 as one of them as well, because that's combined systolic and diastolic, but you may only see systolic, and then you see systolic, you think, okay, that's right. That's what they're testing you on. Can you get to the highest specificity? Do you know how to do that? And this is exactly what you need to be aware of. Don't memorize these unless you're actively working in cardiology, but I50 is the parent code. That's CHF. Then you're able to further identify that where there is left ventricular unspecified. That's a standalone I50.1, or I50.9 unspecified. We don't know. Then again, I50.2, that's systolic, and I50.3 is diastolic. We're going to talk about what the difference in those are. Or the patient can have both, where you have combined systolic and diastolic heart failure. Other heart failure, the code set defines other as we've identified it. But out of all of the codes that we have available that you see in front of you, none of them fit the diagnosis that's been given. And that's why other is used, the I50.8. and then 9 unspecified. And there's the ranges. Just a quick reference. And if you're in our club, you would be able to look at this slide, reproduce it, or be able to take it and make yourself a nice note to put above your monitor to save you time in your coding. I wanted to kind of highlight what in EF or in ejection fraction is, which you have to forgive me, but I often say injection fraction. That is not correct. It's ejection fraction or EF. That's why I say EF. Uh, and what the metrics are for that, you definitely do not have to have this memorized because we cannot code off of that. We can look at it and say, "Oh, okay, they said that it's, systolic dysfunction," and then, you got to go back and make sure the provider documented it in their documentation. But we can't, just like we can't pull up a lab test and say, "Oh, that person's blood sugar is too high. They're diabetic," or again, they have high cholesterol. Look, there's their LDLs and all that other stuff. No, we're not allowed to do that. But you do need to be aware of what it is and how it's often used to do CHF and say what type of CHF it is. Uh, Ultimately, ejection fractions will let them determine the level and if how much of the left heart is involved in the right side of the heart. Now, let's talk about those two different types. Again, you don't have to have this memorized, but it's good to be aware of it and it helps you with the verbiage and the terminology. When a person starts getting CHF, it tends, and notice I put this in italics, uh, or slanted it a little bit in the italics. uh, Often it's left ventricular. That's where it usually starts. We get fluid buildup, the lungs and the shortness of breath starts is one of the first signs. Sometimes it can be more than that, but that's kind of that. Hey, I've been really short of breath. I've got tightness in my chest, and I can't walk across the room like I used to. Then we get left ventricular heart failure. It can be systolic, maybe systolic. Now, that's still the left ventricle. It just isn't strong enough to pump that. Now, you notice that the left ventricle, the fluid starts to back up, but now that we've got that backup going on, now that side of the heart's just wearing out. It's not as strong as it used to be, and as a result, we're going to get some other signs and symptoms. Uh, then we start moving into diastolic, and that means that the heart can't relax. So not only can it not pump, and it doesn't have the strength to pump, but it doesn't have the strength to relax and open back up. And when it opens up, it sucks into the next chamber, right? So not only is it pushing, but it has to have that sucking motion to also work. So we're losing both areas of function, systolic and diastolic. Ultimately, what this leads to is right heart failure. So we start in the left, the ventricle loses the ability to really uh, um push that fluid, the blood. We don't have the strength anymore to push the fluid, and then we don't have the uh, ability to open back up so that it can suck it on through to the rest of the way through the heart, which wears out the right side of the heart. The right side of the heart is going to be is going to be uh, uh, more advanced stages. So by the time you get to that point, and that's where you really start seeing the signs and symptoms: fluid in the legs, in the lungs, swelling. If you see a person with really swollen, an elderly person especially, with very swollen legs and ankles, and even that funny pinkish color and dry skin, uh, they probably have CHF. A lot of times they'll have a round belly too, and they can be skinny and they can be obese. It doesn't matter. Ashley says, I'm a brand new cardiac coder. It is so great to finally understand the documentation I've been reading. Thank you for explaining things so well. Ashley, this is this is how I learn the code set. Uh, I find that if someone can just explain not just how to find the codes, but the disease process behind the scenes, it kind of opens up and makes the codes make sense, right? Because technically we're translating it. So it's like saying, I learned Spanish in high school and I can say lot of things and I can read it really well. Can't always understand what I'm reading, but my pronunciation is excellent. However, when I speak with my native Spanish speaking friends, I'm usually lost. And because it's lost in translation because I don't understand the language enough. And it's like not understanding the disease process enough for us to be able to translate. It's another language, the medical documentation into the code set that we need to do. So thank you for Ashley for saying that. That makes me feel good. Mary says, if the patient has diabetes associated with CKD, can you still combine the hypertension and with CHF and CKD? Absolutely. And I'm going to show you that. So at least I think I've got that on here. Yeah, I think I do. If I don't, absolutely, Mary, you do. That is a causal relationship with the heart, the lungs, and the kidneys. And uh, so the heart, the lung aspect of it is mostly the fluid buildup and things, but the lungs start to wear out as well. Now, some coding tips. I'm not going to read all of this because there's no sense in me explaining every little bit, but I'm going to break it down for you. The code set allows for you to code systolic and diastolic and combined, right? We saw that with those code ranges, right? We've got 1, 2, etc., all the way down to 9. So systolic, now we know, is that the heart doesn't have the ability to squeeze and pump the fluid anymore, right? And it's the most common. That's the first thing that wears out. Then the diastolic means that it can't relax and you do that sucking motion to go ahead and pull the pushed blood through the rest of the heart. So we're pushing, but we've also got to suck that fluid on through. And that's diastolic, and that usually happens next, but a person can have one or the other, or they can have both. Now, combined, you'll see that used a lot, that term combined, and that means that the patient has systolic and diastolic heart failure. We have a code for that. So you don't have to code for systolic and then turn around and code for diastolic. No, you've got systolic, systolic on diastolic. Now, we can also have biventricular. That term is what it means is that both the right and the left ventricles, so the right side and the left uh, side, are losing their ability. They're failing at the same time. That doesn't happen exactly. Now maybe it gets to that stage, but and I don't understand the biventricular as much. It's much more in depth. However, what they're saying is it's not systolic and on diastolic, meaning the systolic happened and then the it wore out the other side of the heart. What they're saying is no, both the right or the left and the right side of the heart, the ventricles, the lower chambers, they both are failing at the same time, or they failed at the same time. High output is defined as you have heart failure. Okay, the ventricles have worn out, but the demand for oxygenating the blood outweighs the heart's ability to produce the oxygenated blood to the rest of the body. So this ends up causing anemia, and it can also cause hyperthyroidism, which you think, what? I wasn't even thinking the thyroid was going to get involved. That's a gland. But actually, it does. Remember how we mentioned that when the heart can't pump and do its job properly, the other organs start to fail. And we saw the lungs fill up, and the abdomen fills up with fluid, and the kidneys are affected. So there you go. And then end stage is that the heart just can't fill up with blood anymore. It can't fill up, it can't contract, and it just is not able to get oxygenated blood to all of the end parts of the organs. This ends up in organs starting to fail. And honestly, from what I read, it seems like the kidneys are the first to go, the lungs are second, and then you get hypoxia, and then ultimately death is you succumb to that. So the heart wears out. It's still working, but it's not able to do its job anymore, and the extremities are affected, and the lower extremities are affected to the extreme. You see this when the person not only has edema and swelling, but they have molted skin, which means that it just looks bruised, and it's not one bruise. It's one big. It looks like one big giant bruise, and the skin starts breaking down. Honestly, just go Google CHF images, CHF lower extremities, and then they'll give you lots of pictures of that. More tips for the coding that you need to be aware of is that, acute and chronic, we we know that's pretty basic. Acute is sudden onset, and chronic is just an ongoing problem. CHF is chronic heart failure, but can have an acute aspect. You can have acute um, heart failure, and you can have acute on chronic, which you will see in the documentation. And that's where you have the patient has CHF, but they have an acute exacerbation. So something has tipped the tide, and it's gotten worse suddenly. We have that in COPD. We have that in all kinds of other diagnoses that we look at. Acute exacerbation there. Unspecified, I explained that unspecified is we just don't know the severity yet. We're still doing testing. We need, we're sending them to specialists. We got to wait for that to come back. Or they just didn't diagnose it or tell us in the documentation. And I50.9, they just keep using it again and again because that's the only code they know for CHF. That happens a lot. Elizabeth says, I remember the diastolic systolic by rhyming with fist. I would also make a fist for the squeezing action, then open for the act of rest. That's a good point. That's I like that. I'll use that going forward, Elizabeth. That's very, very beneficial. So if any of you guys are educators out there, or you're working in a team to help each other to pass the credentialing exams, pass that along. Now we have moved to when there's end stage heart failure, also code I50.84. And when you have failure due to another condition, CKD, rheumatic heart failure, you're going to code the causal condition first. So the patient has, say, ESRD, so N18.6, and it has resulted in the CHF, and and caused, especially when you have acute exacerbations and stuff. Note that your treatment for all of these really depends on where you are at severity, and the the uh the severity, in other words, how far the disease process has gotten. That determines. Absolutely, one of the first thing they do is they put you on a diuretic. And when CHF patients get put in the hospital, they go to the ER quite a bit. They usually diurese them, or give them a lot of Lasix, and they just start dumping fluid. And when that happens, then they can breathe a little bit better and stuff. They manage their fluid. They take away all their salt. Absolutely no salt. There's plenty of lifestyle changes and diet restrictions that are involved, not just taking away salt, but you have to manage the fluid intake of a person. They're usually always on diuretics. Lasix is the key one that's most often used, and ACE inhibitors. You'll see those in the patient. To wrap up, this is the last slide, letting you know that there is that trifecta, that we've got the heart and the lungs and the kidneys. And when you have any type of heart disease, it's going to affect the lungs and the kidneys. Whenever you have any lung disease, it affects the heart and the kidneys. And whenever you have kidneys disease, it affects the heart and the lungs. And the code sets reflect that. This is where you get those guidelines, and that's where you look at those hypertension codes that I showed in the one side. And when you look at the code ranges and you see that you have the option of hypertension with CKD and things, you don't see the pulmonary codes as much in those, but they absolutely are affected. But heart and kidneys always have that relationship. When you know that, then you can expect that on exams and tests. They'll test you on those things. Uh, anything that has a cardiac issue and a kidney issue, you're never going to use I10 by its. You'll probably be using something else, and that's an easy test question to create. Let's see. I think that's about it. I'm not sure if I missed any of the questions. Ashley had said that she was a new coder and really appreciates getting to understand that disease process. Very, very important. It really does help you. That's why when you go into this career, it's important to know anatomy and physiology. Even if you've had courses in the past and you're getting ready to test, if you don't have a firm grasp of anatomy, physiology, and terminology, you need to go jump out and take an MTA course. And we have a great one, by the way. Also, I would encourage you to oh, well, see, and this shows you how much the anatomy is involved in us learning. Uh, and then also, uh, if you were curious as something else that would help, I would consider taking a pharmaceutical education. That we have a great pharmaceutical course that bumps up your knowledge. You would learn about those ACE inhibitors and what's the difference between an ACE inhibitor and some of the other medications that are used and what they're commonly used for. That saves you a lot of time in the real world. Have to have that under your belt. All right, guys. Really, really appreciate you joining us. Don't forget that we have an amazing community in our club, cco.us/club. We continue these conversations. We have people that share interesting scenarios or have questions about scenarios. And also, if you have questions about the disease process, we're there to help you or teach you how to find great resources. Also, don't forget, we are on YouTube. Our YouTube channel is Medical Coding Cert. Please, if you're watching us on YouTube, give us that thumbs up. That helps us in the ranking, and it lets others know that we're giving you valuable content. We'd like to be able to share that with others. You can subscribe, and that way you'll know every time that we are going to put out education for you. We do a lot of free education. And I think if you're joining us on LinkedIn, you can do the same thing. You can share, and absolutely on Facebook. We appreciate you, and let us know if there's something specific you would like to learn more about, whether it be a disease process or maybe combo codes or scenario that you're struggling with. And that could be a topic. We have a place for you to put in topics, or you can just put it in the club. Either way, we're here to help. Thank you, guys.
Our online medical coding course was created specifically for beginners to learn everything they need about medical coding. The course includes a personal coach, 9 months of access, 24/7 online videos, transcripts, and exams. You can learn more about our medical coding course at www.cco.us/PBC.